All right, let's dive into something that's often overlooked in critical care. When we think about a loved one in the ICU, fighting for their life, our focus is naturally on their physical recovery, healing wounds, getting off a ventilator. But what if one of the most common and, well, damaging complications is actually happening inside their head, profoundly impacting their mind, often right under our noses?
It's a critical point, definitely, and one that the material you've shared for this deep dive really illuminates. For too long, conditions like agitation and delirium in the intensive care unit were almost accepted, like an unavoidable part of critical illness.
Right, just something that happens.
Exactly. So our mission today is to sort of cut through the medical jargon, reveal the true scope of these frequently misunderstood brain dysfunctions, their hidden dangers, and also the transformative new approaches that are redefining critical care. The data really demands our focused attention, showing a far more serious picture than many might realize.
Okay, so let's start by clearly defining what we're talking about here. These aren't just, like, vague terms. First, there's agitation. We might think of someone simply being restless, but in the ICU context, our sources define it as a psychomotor disturbance, a specific kind of excessive motor activity coming from inner tension.
Precisely. And this inner tension, it shows up as non-productive, often repetitive behaviors, pacing, fidgeting, maybe hand-wringing, pulling at lines, or just an inability to sit still. It can range from, mild discomfort to really severe, even life-threatening states. A patient might pull out their breathing tube or other vital catheters.
Wow, okay, that's serious.
It is. And that can open the door to major risks like hospital-acquired infections, low oxygen levels, or the patient fighting against the ventilator, which really throws their body's chemistry out of balance.
And what triggers this kind of agitation? Is it just the sheer stress of being in the ICU?
Well, it's multifaceted, lots of different things. Internal factors like metabolic imbalances, infection, or low blood pressure are common culprits. But it's also about the environment itself. Things like unmanaged pain, the constant noise in an ICU, or even withdrawal from substances like alcohol.
Yeah.
And what's particularly striking is how many commonly used ICU medications can actually contribute to agitation rather than helping it.
I see. So it's not just discomfort, it's this complex mix of internal and external factors.
Yeah.
And running parallel to agitation, we have delirium. This feels like a concept that's often misunderstood, isn't it? How do we define it specifically?
Yeah, delirium is basically a sudden and acute disturbance in a patient's awareness and thinking. It often fluctuates pretty dramatically throughout the day, and critically, it's a direct physiological consequence of a medical condition, a substance, or a medication. It's not a pre-existing mental health issue. Historically, it was often mislabeled things like ICU psychosis or acute confusional state, which meant it was significantly underrecognized for a long time.
So it's really more than just a patient being, difficult or confused. We're talking about specific diagnosable brain dysfunctions. And our sources point out different types of delirium, too. What's really counterintuitive for many of us, I think, is that the quieter form, what's called hypoactive delirium, might actually carry a worse prognosis. Can you unpack why this often missed form is so, well, insidious?
That's a crucial insight, absolutely. And you've hit on its core danger. Delirium comes in hyperactive, hypoactive, and mixed forms. Hyperactive delirium, with the combativeness and agitation, that's obvious. It puts both patients and staff at risk.
No, you'd notice that.
Exactly. But hypoactive delirium, where patients are withdrawn, quiet, inattentive, that's far more prevalent, far more easily missed. Because it's subtle, it often goes untreated. That leads to delayed recognition and intervention, and consequently, yes, it can be associated with a worse prognosis. It really highlights the challenge of detection in a busy ICU setting.
Okay, so we've identified what these conditions are, but what's the real cost? The sources you've provided paint a pretty stark picture, actually.
Right.
The consequences, immediate and long-term, go way beyond what many might imagine.
Indeed. The immediate impact on a patient is significant. Longer stays in the ICU and the hospital overall, increased costs, and higher risk for complications like those hospital-acquired infections we mentioned. For patients on mechanical ventilation, delirium can prolong the time they need that breathing support. But the long-term picture is where it truly becomes sobering.
That's the real aha moment, isn't it? The fact that it doesn't just, clear up when they leave the ICU.
Okay.
What are those lasting consequences?
Well, the material underscores a crucial shift in how we understand this. Delirium isn't just some temporary side effect of being critically ill.
Mm.
It's an independent predictor of severe, persistent negative outcomes.
Okay, like what?
Like each additional day a patient experiences delirium increases their risk of dying by a staggering 10%. That's within 6 to 12 months after discharge.
10% per day.
Per day. Beyond mortality, survivors often face physical disability, significant long-term cognitive impairment, sometimes lasting a year or even more. And there's a higher risk of developing depression and PTSD, post-traumatic stress disorder. It profoundly affects their quality of life long after they leave the hospital. It really highlights it as a true organic brain dysfunction.
Given consequences like that, the imperative is clear. Prevention is key. And to prevent, we have to understand the root causes. Our sources outline what sounds like a perfect storm of factors converging in the ICU, often with significant overlap between agitation and delirium. What are the main categories here?
Yeah, they tend to fall into three key areas. First, the acute illness itself, severe conditions like sepsis, organ failure, liver, kidney, heart, low oxygen levels.
The primary reason they're in the ICU.
Exactly. Second, patient vulnerabilities. Things like advanced age, maybe a history of dementia or stroke, alcohol abuse, even sensory impairments like poor vision or hearing. These factors make a patient more susceptible.
Okay, and then there are factors within the hospital environment, even the care we provide, that can inadvertently contribute. What are these iatrogenic or environmental factors?
This is absolutely critical. The very tools and treatments we use can sometimes contribute. This includes things like physical restraints, the discomfort from central line catheters, and yes, many common medications.
Which ones?
Benzodiazepines, for instance. They're widely used sedatives, but they are particularly implicated in exacerbating or even causing delirium. Certain opioids, anticholinergics, even some antibiotics can also play a role. Clinicians often use these mnemonics, like I watch death, to help recall all these varied risk factors. It emphasizes that everything from infection to withdrawal to environmental toxins needs consideration.
Wow. It's easy to get lost in the medical terms, but when you think about that 10% increased risk of dying per day, that's truly sobering. Expert, when we think about these brain dysfunctions, many might hope for just one single identifiable cause, but the material suggests it's far more intricate, right? A real scientific puzzle. What are the leading theories trying to unravel this complexity?
You're absolutely right. The pathophysiology is, well, it's poorly understood, but it's undoubtedly multifactorial. It's a complex interplay of various factors rather than just one single pathway. One leading theory, the monoamine axis hypothesis, points to imbalances in brain chemistry, like an excess of certain neurotransmitters and maybe a depletion of others.
Okay.
Another, the neuroinflammatory hypothesis, suggests that the body's own inflammatory response to the acute illness can actually damage brain cells and blood vessels, contributing to delirium. And then there's the cholinergic deficiency hypothesis. This one focuses on impaired oxygen metabolism in the brain, leading to a shortage of a key neurotransmitter called acetylcholine.
So definitely not a straightforward A causes B situation. This complexity implies that finding some kind of magic bullet treatment is pretty unlikely, doesn't it?
Precisely. Understanding these diverse pathways really suggests that a holistic approach, one that addresses multiple aspects at the same time, is probably the most effective strategy rather than just targeting one single mechanism.
Given how common and how serious these conditions are, effective assessment must be absolutely paramount. But our sources highlight that, despite knowing its importance, delirium often goes unrecognized if it's not routinely screened for.
It's a significant challenge, definitely. The Society of Critical Care Medicine strongly recommends routine monitoring. For agitation and sedation levels, the Richmond Agitation-Sedation Scale, or RASS, is the most validated and widely used tool. It's a quick, 10-point scale that helps clinicians consistently assess a patient's level of alertness and agitation. It takes less than 20 seconds usually.
Okay, that sounds efficient. And for delirium specifically, how do clinicians detect it, especially that really subtle hypoactive form we talked about?
Right, well, the gold standard for delirium is the confusion assessment method for the ICU, the CAM-ICU. It's designed to be quick. Nurses can usually administer it in just a minute or two, and it's highly accurate compared to, say, a full psychiatric assessment. It identifies delirium if a patient has an acute change or fluctuating mental status plus inattention, and then either disorganized thinking or an altered level of consciousness.
Got it.
There's another excellent tool as well, the Intensive Care Delirium Screening Checklist, or ICDSC. This one also helps identify something called subsyndromal delirium, where a patient has some, but not all, of the features. And that's a critical distinction because even subsyndromal delirium carries a worse prognosis than no delirium at all. Still better than full delirium, but worse than none.
So we have these excellent tools like CAM-ICU and ICDSC,
Yeah.
but you mentioned the challenge of detection earlier. What happens if a patient is heavily sedated? Does that make it harder?
It certainly can, yes. Ideally, these evaluations should happen after sedation is lightened or interrupted, whatever that's feasible, because sedation can definitely mask symptoms. However, the key takeaway is that evaluations should not be skipped just because a patient is sedated. Missing the diagnosis is far more detrimental than dealing with the challenge of assessing through some level of sedation. The challenge isn't really the lack of tools, it's the consistent, rigorous application, especially for those subtle forms.
Okay, so once agitation or delirium does appear, what's the first step in management? It's not about jumping straight to medication, is it?
Absolutely not. No. The initial priority is always to rule out any immediate life-threatening problems like low oxygen, maybe a collapsed lung, low blood pressure, or other acutely reversible causes like severe pain or low blood sugar.
Right, the urgent stuff first.
Exactly. Those must be addressed first. But the true cornerstone of management, and really the most effective strategy for reducing both the prevalence and severity, lies in comprehensive non-pharmacologic treatment bundles.
And that brings us to the ABCDEF bundle. It sounds like a holistic, almost common sense approach to patient care, but clearly it's deeply researched.
It is exactly that. The ABCDEF bundle is a comprehensive, evidence-based protocol for ICU care, and adhering to it has been shown to improve critical patient outcomes in a dose-dependent fashion. More adherence, better outcomes.
Okay, so what are the components, A through F?
Right. So A is for assess, prevent, and manage pain, consistently assessing and treating pain. B is for both spontaneous awakening and breathing trials, SAT-SBT.
Yep.
Basically, daily trials to lighten sedation and get patients breathing on their own sooner. This reduces ventilator time and long-term cognitive issues.
Makes sense.
C is for choice of appropriate sedation. This is crucial. Avoiding benzodiazepines for general delirium management, as they can often worsen it. Dexmedetomidine, another sedative, has shown benefit over some others here. D is for delirium monitoring and management. Routinely assessing for delirium using those tools like CAM-ICU or ICDSC. E is for early mobility and exercise, getting patients moving as soon as it's safely possible. This significantly reduces ICU and hospital stays. It's huge. And F is for family engagement and empowerment, involving family members as active partners in the patient's care and helping to reorient the patient.
Wow. So it's really not just about drugs at all. It's about the entire patient experience, managing pain, waking them up, getting them moving, having their family involved. It sounds like a complete reevaluation of the ICU environment itself. Beyond the specific bundle, are there other non-pharmacologic things that can help?
Oh, many, yes. Simple things, often. Like establishing proper sleep hygiene, dimming lights at night, promoting natural day-night cycles, controlling noise as much as possible.
Basic comfort measures.
Exactly. Providing visual and hearing aids if needed, removing unnecessary invasive devices like catheters or restraints when possible, and treating underlying metabolic imbalances are all crucial. Even things like music therapy can play a role in optimizing the environment.
That's such a huge shift from what many might imagine ICU care to be all high-tech and interventions. But what about medications? There must be some role for them, even with this big emphasis on non-pharmacologic strategies.
Yes, there are vital nuances here. While benzodiazepines are generally not recommended for delirium itself, they remain the drug of choice for specific situations like alcohol withdrawal syndromes, delirium tremens, and seizures. That's a critical distinction.
Okay, so specific uses, not general management.
Correct. Antipsychotics, like haloperidol, are also generally not recommended for routine use. The evidence just isn't there. They should really be reserved only for patients who pose an imminent risk to themselves or the staff due to severe agitation.
Got it. And statins. You mentioned conflicting evidence.
Right. With statins, some early retrospective studies hinted at a benefit for delirium prevention, particularly after things like cardiac surgery or in early sepsis, but the more robust randomized controlled trials have not shown a reduction in delirium, so the jury's still out on that one. And finally, mechanical restraints. They should really be avoided if at all possible. They can actually increase agitation and delirium, plus they carry their own risks like nerve injury or worse.
So the big takeaway isn't just use fewer drugs, but more like use the right strategies. And often those strategies are much more holistic and involve basic foundational patient care, like ensuring good sleep and getting people moving.
Exactly. It's a paradigm shift. It's towards viewing the ICU environment and the patient's overall experience as integral to brain function and recovery. The ABCDEF bundle is so powerful because it integrates all these elements into a synergistic system rather than just looking at isolated interventions.
So despite how far we've come, it sounds like there's still this fascinating push and pull between what we know works, what we actually do in practice, and maybe what we could be doing. The sources point to some key tensions and future directions that are still evolving. For instance, you mentioned earlier that delirium is still frequently underrecognized. Why do you think that gap is persisting, given we know how severe the consequences are?
That's a really significant tension. Despite this strong evidence of severe long-term consequences, delirium is still often considered an expected event by many clinicians, almost like it doesn't have profound long-term impact. This points to, well, systemic issues, educational gaps, maybe even cultural barriers within medicine. A fundamental mindset shift is still needed across the board.
Right, and the confusion around medications.
That's another tension. The clear evidence against routine antipsychotic and general benzodiazepine use for delirium often clashes with the critical need for these same drugs in withdrawal syndromes. Differentiating these scenarios in a high-pressure ICU environment can be challenging.
And that statin uncertainty you mentioned. What does that tell us about medical research generally, where sometimes early promise doesn't always pan out in bigger trials?
It's a classic example, really, of why we need those robust, randomized, controlled trials. Promising retrospective data can generate a lot of excitement, but if it doesn't hold up in more rigorous studies, clinicians are left in this state of ambiguity. It just underscores the need for more targeted research to pinpoint exactly when and for whom specific interventions might genuinely offer a benefit.
So looking ahead then, where do you see the most promising novel directions and opportunities for improving care in this area? What's next?
Well, one of the most important emerging patterns is this concept of subsyndromal delirium, identifying patients who show some but not all of the symptoms that opens a critical window for early intervention. We could potentially prevent full delirium and improve outcomes significantly.
Intervening even earlier.
Exactly. Similarly, more research and just refined detection strategies for hypoactive delirium are crucial given how common it is and its potentially worse prognosis. And honestly, the dose-dependent success of the ABCDEF bundle itself really reinforces the power of comprehensive, sustained systems-level change. It shows us what works when implemented fully.
It sounds like the most critical next step isn't necessarily waiting for a new breakthrough drug, but maybe a fundamental change in how we practice and actually implement what we already know works.
Absolutely. I think the most impactful immediate next step is a mandated, continuous, and robust education and implementation campaign for the ABCDEF bundle across all ICU settings. This needs strong organizational commitment, resources,
Right.
real backing to truly transform care and improve long-term patient survival and quality of life.
Beyond implementation.
There's also huge potential for technological innovation in delirium screening, maybe leveraging AI or machine learning to detect subtle behavioral cues, especially in patients who can't communicate easily, and deeper integration of family education and empowerment. Turning families into active, informed partners in care is just invaluable.
Okay, so this deep dive has really shown us that agitation and delirium in the ICU are far, far more than just confusion. There are complex brain dysfunctions with profound, lasting consequences, impacting everything from how long someone stays in the hospital to their long-term cognitive health and even survival. We've kind of moved from viewing them as just an expected, almost inconsequential event to recognizing them as critical, modifiable conditions, demanding proactive, holistic care, really epitomized by that ABCDEF bundle. So what does this all mean for you, the listener? It means that armed with this knowledge, you can approach discussions about critical care with a much deeper understanding, whether it's for yourself or a loved one. You understand the importance of routine screening now, the value of early mobility, why certain medications might be avoided or favored. You see the ICU not just as a place of physical healing, but as an environment that profoundly impacts the mind. And here's a final thought. Imagine the sheer number of lives that could be profoundly altered, not just saved, but truly improved, by aggressively preventing just a few days of delirium. What if addressing this often invisible condition could fundamentally transform the recovery trajectory for millions, shifting the focus from merely surviving critical illness to actually thriving afterward? It really challenges us to look beyond the obvious physical battles, doesn't it?